Like I said, people will probably trickle in, but we'll kind of get us rolling because we have two awesome speakers here to join us today. Today the goal is to really talk about from idea to impact, building rigorous and publishable medical education scholarship. As Naomi and I started thinking about this topic and we were sort of hypothesizing and talking about getting your med ed work published, we were thinking about sort of the end product, but really in discussions with Melissa and Su-Ting, it really brought us back to the beginning and thinking about how do you set up your project in a way that ultimately leads you to the best success possible when you go to publish your work. And so we're going to take a little journey with them today. So we have two awesome speakers. Melissa Klein is a professor of pediatrics at the University of Cincinnati and the associate director of the Cincinnati Children's Peds Education Center. And also of their Office of Academic Affairs and Career Development. And she is an associate editor at Academic Pediatrics, along with Su-Ting Lee, who has won many notable accomplishments, is a professor of pediatrics at UC Davis, their residency program director and the vice chair of education, and has served on many different educational committees. Actually, reading your CV online, Su-Ting, gave me like lots of interesting things to look up and new groups to learn about. So people can check into that. And she has been honored with many different awards for her work in medical education and in career development and academic development. So we're very excited to have both of them here with us today to talk about how we go on this journey from idea into scholarship and ultimately publication. So Melissa, I think you're going to take it away.
So hello everyone. I thank you so much for having Su-Ting and I. I think we are partners in crime at the Academic Peds, as we're two of the associate editors for education, and we're thrilled to be here today. Okay, so welcome. So our objectives for today. So we want to examine how to establish the importance of a topic, describe how to use conceptual frameworks and best practice models, and we'll differentiate between those and where they are both important in medical education scholarship. We want to cover how to build rigor into your scholarship, and then discuss strategies for selecting a journal that best fits your individual scholarship and piece. So we wanted to start off with defining educational scholarship. Sometimes it's thrown around and people mean different things. So we wanted to start all on the same level playing field. So it's the scholarship of teaching is teaching that is studied, improved upon using evidence, and then shared to advance how others teach and learn. It differs from scholarly teaching in that it needs public sharing, the opportunity to apply, and evaluate by others. So putting this on the teaching continuum, so we start off as teachers, and I would say, I don't know all of you, but I know some of you, and we're all great teachers. We work in academic settings. We teach so many different people, and so we are all great teachers, and that's part of our job. That next step is the scholarly teacher. And so that's the teacher who uses the study of science and uses science of teaching and learning and how they teach. They use structured methods to teach. And then what we want to talk about is the scholarship of teaching. So it is all of the above with also the intent to present and disseminate your work. In order to have this, the 3 Ps are what are super important. So your work must be made public, it must be available for peer review, and it must be a platform that others can build upon and learn and continue that learning journey. So for the rest of the talk, we're going to focus on 4 tips in educational scholarship, and I will hand it off to Su-Ting to talk about the first one.
Great. So we'll start with establishing the so what, or why is this important and why do I care, right? So making the case that your topic is important or relevant to others and not just to yourself is really important, right? So when you are reviewing a paper, you'll read it and you go, well, why am I bothering reading this, right? Because it's important to me and it's going to change what I do. So you want to make sure that It's clearly stated in your introduction section. So you need to make a claim or a statement in your work, and then when others ask you the so what, you need to tell them this is important because. And so how do you make that claim? So we'll move forward to the next slide. So Melissa's in charge of the slides for us. The so what. So why is this topic important? So you want to start with the literature, right? You want to embed this into the literature. So what is already known about this topic? And then where's the gap? And then how does your study fill the gap? And why is it important for this study to fill the gap? And then have potentially a hypothesis and a specific aim. And then your story for why this is important for your project, for your scholarship flows from there. But you really need to establish that important premise of the so what, or the importance of this. Otherwise, people are going to stop reading.
So to pick up from the so what, our next big tip is conceptual frameworks. And I just want to, in full disclosure, so Su-Ting and I have done 3-hour workshops on just conceptual frameworks. This is a really, really hard topic. And so we're just going to try to go over it briefly and give you some resources to use. So before we get to conceptual frameworks, we have to start off with Glassex's criteria. And Glassix offers a clear and rigorous framework for defining and evaluating educational scholarship. It helps ensure that our educational work is purposeful, measurable, and impactful. There are 6 steps in the framework, which you can see there. They include clear goals, adequate preparation, appropriate methods, significant results, effective presentation, and reflective critique. What Glassix really helps us as far as educational scholars is it makes our scholarship similar to other types of scholarship and research, whether it's bench, clinical, translational, and that it really establishes that successful educational research takes planning and teamwork, similar to other types of research. So let's start with the first 2 steps of Glassix, the clear goal and adequate presentation. And so you can see here in the clear goal, you really want to think about defining the problem, the purpose for doing the research. This is the so what, and creating that education, that research question that Su-Ting already talked about. Conceptual frameworks will help you in this next step. When you're looking at reviewing the literature, you need to know what is known, where the gaps are. And when you're looking at what is known, looking at what prior methodologies did other authors use to establish what was known, what conceptual frameworks did they use, and might there be a different way to look at it? And then thinking about which conceptual frameworks might be appropriate or might be interesting to look at. Then you can go ahead and identify a conceptual framework. And what we really think about with this conceptual framework is it is a theory that can be applied to understand the problem. I often think of it, it's a theory as to why my learners will learn what I'm hoping that they're going to learn. And so we all have theories on how our learners learn, and conceptual frameworks will help us will help us demonstrate that. And then you'll construct that research question. You're going to narrow it. So you're going to start with the so what and why this is important and the gap. And once you have your conceptual framework, you're going to narrow your research question to be answerable, clear, specific, and measurable. So conceptual frameworks are the theories that ground your work and guide the study's design, educational intervention, and evaluation. I'm going to veer now for a minute for a few slides here. So we're going to talk about best practice models, because this often can be confused for conceptual frameworks. And when you read the literature, we have a whole bunch of authors listed there. Different authors frame this differently, and so it does get quite confusing. The way we are describing best practice models they provide the structure, whether it's structure in how you develop your teaching, your curriculum, your educational intervention, which would be your methods in Glassix, whether it's the structure for assessing your learners, evaluating your intervention, evaluating your curricular or your curriculum or your educational program. Those are going to be the results. And then best practice models will help you organize the scholarship that comes out of it. And that, again, going back to Glassix, is the reflective critique. So to be a little bit more specific, we're going to give you some examples of best practice models that we see frequently in educational scholarship. ones that relate to curriculum development, program evaluation, and evaluation of educational intervention or curriculum. We are going to fly through this though. So the first is curriculum development, and that's Kern, which I think many people know. As a reminder, this is the Kern 6-step approach. It starts with the problem identification and needs assessment, goes through the targeted needs assessment, goals, objectives, educational strategies, implementation, and evaluation and feedback. This, again, is a best practice model for curriculum development and evaluation. The next thing to think, the next set of evaluation models we wanted to share was around program evaluation. So the logic model is one that comes up frequently that is well known amongst educational scholars. Fry and Hemmer is one nice publication from the AME guide on evaluation. I listed an old manuscript of my colleagues and myself where we actually published just the logic model on a program that we were developing. So when I think about logic models, I think about these different categories of how to set this up. So when you're thinking through in a program, you're thinking through what inputs do we need? What resources do we need? What do we have? What are those immediate outputs and activities? And then what are the short-term outcomes, medium outcomes, and then long-term outcomes? For the outcomes, again, from the work that I do, I like to think about outcomes in different ways. And so here you can see I have it as learner outcomes, faculty outcomes, and program outcomes. When I'm working on an educational program around something that has a community-based participatory or community organization, I will have outcomes related to communities and families and community members. So you can change what those outcomes are. And then again, on the logic model, you really want to talk about what the impact of achieving all of these things are. And then the third best practice model that we want to share is Kirkpatrick. And this is for evaluation of educational interventions and curricula. Again, here's a very familiar pyramid to most people on this call, I think. So this is the New World Kirkpatrick, which Su-Ting's going to talk about a little bit later. So I won't go into much detail here, except that it has the 4 levels: reaction, learning, behavior, results. And you can see those arrows are from New World Kirkpatrick. That's the newer, it's not new anymore, but the newer formation, newer rendition of it, where you're looking at process level measures and how those can be outcomes as well. So in summary, best practice models, I think about them as organizational structures. When we as editors and reviewers are reading your work, if you use these best practices, and oftentimes it's helpful to have, we use Kern to create the curriculum and Kirkpatrick or New World Kirkpatrick to set up our evaluation. That signifies that you've used rigor in the design of both your intervention and your evaluation. They provide nice structure for the analysis and the interpretation, and really help some of that generalization, knowing that we have that rigor to start. So now to step back to conceptual frameworks. And as a reminder, these are the theories that ground our work. They guide us in both our study design, our educational intervention, and our evaluation. So just as a reminder, there's not one conceptual framework that is correct. If you have a curriculum that you're creating or a research question that you have about something you're doing in palliative care, there may be many conceptual frameworks that can shape your research question. And one conceptual framework can actually shape many different research questions. And I'm going to give you an example in a minute. Just remember that the framework that you select, you'll need to use it to define your specific research question, and then your design and your outcomes. So whatever the pieces in your conceptual framework are, need to really link to the outcomes and the metrics that you study. So here's an example, and I saw some folks do some simulation, and so I use deliberate practice because that's one that we often talk about, think about, use in simulation type work. And I think most of us have either been a participant or a leader of simulation work at some point. So deliberate practice, just as a quick review. So you have a task that is performed, and then there is feedback. There is rapid cycle deliberate practice. We won't go into that, but there is feedback from an expert at some point in that goal. Sometimes it's multiple points of feedback. And then the learner then thinks about how I can do it better, and they do it again. And then there's more feedback. And you continue in that cycle until you have competence or mastery, or depending on what is of interest. So I am not a palliative care doctor. I'm a general pediatrician. So I try to make up something using deliberate practice and something related to palliative care. So I hope I got this okay. But if we just use deliberate practice as our conceptual framework, I came up with several potential research questions that could be used that relate to deliberate practice. So my first one was, does a deliberate practice-based palliative care curriculum lead to improvements in residents' observed communication skills during family meetings? And I mean the goals of care type meetings. And so you can see we're using deliberate practice, and then we'll need to know, we'll need to create our curriculum using Kern. We need to think about the evaluation, but we want to observe their skills, and we want to observe how their skills change with that deliberate practice model. Another potential question I came up with is, how does the length of time between performance of leading a family meeting, which is the task, and feedback from a faculty coach impact residents' self-perceived competence and communication skills? So here we're using deliberate practice, and we're trying to decide, does that feedback need to be right away? Can it be a few days later? Does it help if the coach stops the learner several times in the first time? And so we're looking at what is the ideal way to apply deliberate practice to improve resident competency in communication skills. So here's another one. So how many deliberate practice cycles are required for residents to meet whatever those predefined competency curricula are for leading family meetings as measured on a standardized observation checklist? So I made up, there's a standardized observation checklist. I don't really know if there is. If there is, that's wonderful. So the research question is, how many experiences with the feedback from a teacher or coach that's an expert, how quickly do residents reach that competence? And then the last one is a little bit different. So what types of feedback from a faculty coach are effective in improving resident palliative care communication skills? So for someone who wants to do more qualitative, this to me was, you're using deliberate practice, you're getting that feedback, you're going through the cycles, but using some qualitative approach to learn from the residents what were the most important parts of the feedback that helped them improve. So you can see these are all different. You can see that hopefully they all impact or have something to do with resident communication with families, but the metrics that you would need to evaluate for each of these are quite different. So the biggest question is, so where do I find these conceptual frameworks? Because deliberate practice does not work for everything. I wish it did. It's my favorite because I understand it really clearly. So it's complicated. So there's medical education, health science, and social science researchers can help you explore. So if you have some PhD colleagues, especially in social sciences, educational librarians, if you have librarians at your institutions, can be very helpful. We published this paper many years ago now that have like the top 8 or so that we see frequently. And then this is an online free resource, and I love it. So I am really promoting it here. So it's called MedEd Mentor, and there's many different ways to engage with this. So if you forget everything except MedEd Mentor, you can start by lessons, and it actually walks you through the MedEd Mentor approach, how to use conceptual or frameworks or theories in medical education research. You can also use this theory suggester. I can't say that 3 times. And so you can put in your research question, your research phenomenon, what are you thinking? And it will give you like 3 to 5 theories. You can get 5 of them for free, and then I guess you have to start paying. But this is another way if you want to look at your specific question. And then I like this one too. They have a theory database, And this gives you like their top 10 theories in medical education, which again, I think a lot of our work is likely due to one of these top 10. So this is a really helpful website. So going back to Glassic, and how that relates to conceptual frameworks. So we talked about clear goals, we talked about adequate preparation, and we've talked about how conceptual frameworks help you in both of these. The conceptual frameworks also direct you to the outcomes. So if you're thinking more of that qualitative of what are the pieces, you definitely don't want to do a survey of completion. If you are thinking more about how many cycles, you're going to need to keep track of that, whether that's through direct observation or a video or whatever. And so knowing your conceptual framework and how that influences or how that helps you create your research question will then create your methods and what outcomes that you will study. And with that, I will pass it off to Su-Ting for tip number 3.
So, conceptual frameworks, huge deal. Thank you for taking 3 hours and synthesizing that into much shorter amount of time. And I know it was a whirlwind there, but that MedEd Mentor, great opportunity for you guys to look at that and use that. And I'm going to say, if you submit to us in academic peds, one of the most frequent things I'll put back as a comment is, if you don't have a conceptual framework, what is the conceptual framework you used for this? And other places will just reject you. So please start with a conceptual framework as you're building your methods. So, and your research question. So we're going to talk now about the rest, kind of the other main methodological flaws that we see and we talk about and give feedback back to. So again, your research or scholarship, it's a story. So you are making your case and weave together a story. So you're making the case for why this story is important and the importance of your topic. You've chosen a conceptual framework. You've developed a research question based on your conceptual framework and your important topic. And then you need to choose a methodology that actually incorporates that in and addresses your research question, hopefully with a conceptual framework. So let's go talk a little bit about this. So these are some of the common study design challenges that we see. And they're not all of them, but there's some of them. So we'll talk about each of them. So there are outcomes. Oops, so go back like 1 second, sorry. Outcomes, generalizability, sampling or survey response rates. And we're going to talk about that part mostly because a lot of people do surveys. And so that's why I want to talk about that. And then end with validity evidence. I love the thinking about in terms of you planning ahead for this, because you can't go back and recollect all that data and do the most amazing analysis on the incorrect data that you didn't, or the missing data that you didn't actually collect correctly. So we want to think about that in advance. So let's think about outcomes first. So this is the New World Kirkpatrick's, and the key thing for this is try to use higher level outcomes and try to use as many of these outcomes as you can to build your story, to build that linkage, to convince others that your intervention, curriculum, program, whatever, works. So we're going to start at the bottom and kind of move on up. So the bottom one is generally, unless it's super innovative, it's not going to get you published. So it's a reaction. So demographics, who is involved, reaction, did they like it, right? So it's those surveys of, oh yeah, they loved it, but did it move the needle, right? On top of that, the New World Kirkpatrick part is the yellow part. So the normal Kirkpatrick is the 4 in the pyramid, and the yellow is the New World part they add in there. To really, I think, to think about process for some things in addition. So reaction also includes engagement. Were they engaged during this? Did they think that was actually relevant to them? So we're doing this talk about publishing and educational scholarship, but if it's not actually relevant to what you want to do and what you see for your future, then you're not going to be excited about it. So after reaction is learning. Did they actually learn anything during that time? And I'm going to tell you, people are smart. If you teach them something, they're going to learn it. So really the question is, are they going to retain it? So if I asked you something right now, like right after this, hopefully you'll remember something about conceptual frameworks, but are you going to remember that in 3 months, and 6 months, and a year, right? So are they, in terms of knowledge, not just short-term knowledge gain, but longer-term retention? So change in knowledge, skills, attitudes, and retention. And then the other part is confidence and intent to use those knowledge, skills, and attitudes. So yeah, I might have learned that, but I'm never going to apply what I learned in this palliative care curriculum to the next time I talk to my patients and families and give them bad news. Well, that would be not good. But hopefully they're doing that going forward. And then on top of learning in this, situation here, are you then going to apply it in real life? When you actually go and work with patients and families, when you actually go on your next scholarship project or research project. So are there actually any changes in behavior or transfer of that learning in this supervised environment here to something that you're actually going to do in real life? And then what are the processes that facilitate application of that learning, or monitor or reinforce it in terms of that behavior change and keep that going? So I'm a hospitalist, and so one of the big things is handover, right? And so when we do handover, when they did all of those things in terms of the IPASS handover, they had a whole campaign in terms of the processes to reinforce that behavior change. They had it all over the place, and that's a piece of it too. And then at the top of the pyramid is that return on mission, or that contribution to the organizational goals. And so those results. So that may be a change in learners, a change in patients and family outcomes, right? A change in your program outcomes. So those are the things that you would look at. So that's kind of would be great, but it's also great to make sure that you have consider some things as you move up the pyramid in terms of building that base, so that people can understand that, oh yeah, that change in that patient outcome, that was actually due to this intervention I did. Okay, we're going to go forward. So that's outcomes. So the next challenge is generalizability, right? So I come from a medium-sized program, not like Cincy, which is gigantic, right? So Cincy is really huge. And so that's why most of my studies are national studies, because I don't have enough residents or like palliative care, even smaller, right? Fellows necessarily in your few fellows you train a year for me to go, oh, wow, that's really generalizable. So that's challenging. So we're going to go forward a little bit on that. So generalizability, challenging. So, and then when we think about it for qualitative work, it's called transferability. So I hate reading a qualitative paper and they say, it's not generalizable because blank. Well, they didn't understand that we don't talk about generalizability in qualitative work. We talk about transferability. So please use the right nomenclature when you talk about that, because that's helpful too. But you also want to think about, are the participants similar to the population you want to generalize to, if it's a quantitative study, or transfer to, if it's a qualitative study? So for example, if you want to talk about the whole population of pediatric palliative care physicians, and you only surveyed the pediatric palliative care physicians that are part of, let's say, the AAP's group on pediatric palliative care, are you missing a whole, group with that? And in which case, are you able to then generalize the results to everybody else, right? As you think about that. So as you think about increasing generalizability to transferability, you can consider potentially casting a wider net, potentially expanding your pilot, including other types of learners, consider multi-center. But as you consider multi-center, we're going to go to the next thing. So if you do like a study, like we've seen this all the time, the survey part, people, so through the Association for Pediatric Program Directors, I was part of the research and scholarship learning community or whatever. And so all of the surveys used to go through us that came to the program directors. And when they didn't come through us, I tended not to answer them. So for example, when people just like email you just out of the blue, because they have a list of all the program directors, because all of our emails are like, public out there, and they say, hey, I'd really love you to answer this survey for me on blank. We get so many of them. At least the ones to APD are vetted, and I will answer those, like, because I know they've gone through a certain process, but not the ones where like, oh, my fellow has this wonderful medical student, whatever, has this wonderful idea for a survey. I want to know what is the pediatric palliative care curriculum for nationally, right? And I'm just going to send that out to everybody. Or I'm going to send that out and I want you to send that to, this is what even worse. I want you to send that one to all of your residents because I want all of your residents to answer that question of, what do you know about pediatric palliative care, right? And then your response rate, 1%. And then you send it to us to be published and we're like, I can't like that sampling and response rate. That's going to be, I don't know what to do with that. So let's move forward. So I like this cartoon. So it says, yes, I love responding to surveys. Or no, I toss them in the bin. Oh, 99.8% say, yes, I love responding to surveys. So we received 500 responses and found that people love responding to surveys. Oh, what is wrong with that, right? Well, might be a little bias going on here. So responses from non-respondents may be very different from respondents, especially if it's not representative of the target population. So you think about that. And as you think about going to like casting that wider net just indiscriminately, and you end up with a response rate that's really, really tiny, we're not going to know what to do with that, right? It might be better to strategically choose X number of programs that you want to, that that the program director is going to send out that survey, really maybe do some follow-up surveys, maybe have some way to get a higher response rate in their program and be invested in that, than to send it to everybody and just hope that something happens. So we're going to move forward. So we can give you a few tips on maximizing response rate and trying to minimize confounding and bias. And so we want to maximize the response rate. I'm going to skip to the one in the middle that's in all caps. Make your survey short. The longer the survey it is, the more people are going to stop answering or not even answer at all. As you think about that, organize your survey items intentionally. You want your key questions early, so if they stop your survey partway, at least you've got your most important question answered, right? So as you think about that, unless your demographics are your most important question, consider putting those at the end, especially if they're sensitive demographics, which they're going to not answer or whatever, or consider asking it in a way that it's not going to be identifying, right? You're not going to ask them, what is your program? You might ask them, what region of the country are you from? Right? So as you think about those type of things, you want to, whoops. Oh, you go. Oh, Melissa, you're muted. So this is our checklist. Okay. So you want to maximize effective survey delivery. And oftentimes that may be you're going to send an online survey because it gets sent to hopefully the right people. The only exception to that, I might say, is if you have a captive audience in person. Then you might actually hand out a survey because then you can get them to collect it back into you after that experience, as opposed to, yeah, please fill out the survey, and they may or may not even open the survey, and they're in the room in front of you. So you might consider that. Think about a personalized survey invitation if you know these people. A monetary incentive, it doesn't even have to be big. It could be for your time. I don't know, way back when they used to mail all the surveys, sometimes I'd get $1 or $2. Wasn't that cool? It's oh, I got a $2, and you guilt the person and a pencil or whatever, and you guilt them into filling out the survey for you. Sometimes that works, usually not. But you can, again, short survey, and you want to provide an estimated survey time. So they don't look at it. And if this estimated survey time is 20 minutes, I don't have 20 minutes in my day to answer all your questions, but I could maybe just spare you 5 minutes, 3 to 5 minutes. I could do that. And then if I'm answering the question and I have to look something up because I don't know it off the top of my head, I'm just going to stop. Unless I love you and you're my best friend or something, then maybe I will answer it for you. But otherwise, I'm not going to go look up, what percentage of my residents did blank or whatever. So that's going to be really hard if it's a question that they have to think too hard And then timing. So if you're using learners, consider, do they have some protected time where they're ready in conference and I can hand out the survey to them and make them answer it? Or Melissa said that she does it like sometimes at the beginning of clinic, like for the first 5 minutes of clinic or whatever. So that might be time. Or as you're doing, whatever with the residents or the fellows or the medical students, those might be great times where you already have contact and an audience that is right there with you. And then if you're doing an online survey, sending it to people once, people are busy, right? And so oftentimes you'll need multiple reminders. And I would say like weekly, maybe every 2 weeks, but not less often than that, because then they don't remember if they filled it out or not, if it's like too spaced apart. Okay, go forward. So again, so that's maximize, whoops, go back. So this is minimizing item non-response. So that one is like filling out the survey at all. And this is like to minimize, to make sure that they answer hopefully all your questions. So again, minimize survey fatigue, make it short survey, minimize the cognitive load. You don't want something where they have to think up too hard about it, look up anything. Those things, they're either going to skip the question or just stop your survey. And try not, don't provide the no opinion for attitude or behavior questions because they have an opinion. Just make them commit to whatever that opinion is. And then for paper surveys, so I've made this mistake before when I've done paper surveys. Do a paper survey and you're conserving paper. So you print it double-sided and they only fill out the first side of your survey, right? And they don't flip it over and see that you have other questions on the back. So if you do a paper survey, make it single-sided and it's super obvious, what that is. And then if it's a paper survey, the double data entry responses. For electronic surveys, use skip logic so they don't have to answer every question if it doesn't pertain to them. And then test the survey. Test all the answer choices. Test each answer choice for skip logic, because I made the mistake before of I thought I tested it, but then when it went out, it was like messed up. And then then it's like too late. And then test on different devices. So if it's possible for them to do it on their phone and do it on their computer, test it on both places, because it made it like really funky on your mobile device or work differently. And then consider requiring item responses so they don't accidentally skip something. But don't require it if it's going to make them stop your survey completely, right? So if it's too hard, or if it's a sensitive demographic question, or if it's a qualitative one where you're making them put in an answer, you've seen that probably when residents or fellows or whoever fills out their evaluations and they'll put ... instead of like filling out well, maybe it's just my residents, instead of filling out like a whatever on that thing. So like thinking about what you're actually requiring. Okay. And then, so the last one I'm going to talk about is validity evidence, which is we've also done like a 3-hour workshop on this. So this is going to be the short and dirty. So we always hear people say, I'm going to use a valid tool. There is no valid tool. There is no such thing as a valid assessment tool. An assessment tool itself is not inherently valid or invalid. You need to build evidence of validity for what you're going to use the tool for. So let's say there's validity evidence for the use of Melissa's standardized observation checklist for communication of bad news, filled out by a faculty member looking at it, a resident or a fellow giving that bad news. But you want to use it in a different circumstance. Perhaps you want to use it after a code with a APP or something. So like you think about what is that validity evidence and can I use it, and what kind of additional survey evidence do I need for that? So what tools need validity evidence? Any learner assessment tool needs validity evidence. So that means a survey. So any learner assessments, a rotation evaluation, our pre-post assessments, our multiple choice questions that we make up and we put on there and we're like, oh, this shows that they learned something. Multiple choice tests, in training exams, American Board of Pediatrics exam, USMLE, all of that stuff, OSCEs that we build, observation checklists, workplace-based assessments, all of those things need validity evidence. But how much do you need? Well, that depends on what you're going to use it for. If you're just using it for feedback, you need less validity evidence on that because it's low stakes. But if you're going to use it to decide if someone is going to pass your fellowship and graduate, if you're going to use it to decide that someone is going to be able to be a practicing palliative care physician, and it's a pass-fail type thing, you need a lot of validity evidence if you're going to be making those kind of decisions on that, right? Especially based on like one tool. So this is a framework that I think Melissa and I like to use this one. Messick's validity framework. There's another one, Cohen's, but I like this one better. So I'm going to talk about this one. So it's 5 parts to it: content validity, internal structure, response process, relationship to other variables, and consequences. So I like thinking about that as, content validity is, I like thinking about it as, are you measuring what you're measuring? Internal structure as, how do you know you're measuring what you think you're measuring? And response process is around measurement error. Has that been minimized? And then are the results reliable? Relationship to other variables are, how do results from your tool relate to other assessments of the learner or other aspects of the learner? And then consequences are, what is the impact of the interpretation of the score, especially if it's a pass-fail or something like that. So I'm going to give you a small table just to give you some examples of some ways that you could look at that validity evidence. So content validity is the easiest, potentially easiest. So you can do that by looking at literature. So hopefully you're all doing that anyway to build that argument for why it's important. So you're doing a literature review. Your conceptual framework can build on it. If you want a little more formal or a lot more formal content validity, you can do expert, talk to the experts or have some sort of expert consensus with a Delphi process, all of that stuff. In terms of internal structure, you can look at that with things like, do all the items of the tool hang together to answer to describe a professional fellow or something. And so you may look at that with Chromex Alpha. You may look at that with different things with confirmatory factor analysis. Response process is a way for you to identify and minimize measurement error. So a part of that is, first of all, identifying where that error could come from, and then thinking about rater training. And as opposed to just having a tool and just giving it to a faculty member or somebody to use, hopefully you're training them how to use it. And then looking at things like reliability, like inter-rater reliability, intra-rater reliability, retest reliability. And then for more complicated things, you could look at generalizability theory or decision. So a G study or a D study or decision study. And then for a survey, or you can think about it as, I want to make sure my questions are as clear as possible and they are interpreted the way I want them to be interpreted. And so one of the ways you can do that is through cognitive interviews. Can you please go through my survey and we will talk through it? When you see this question, what are you thinking about? What are your answer choices? Do they make sense to you? And so do that with somebody that would be similar to who you're going to be doing this with, or piloting that to make sure that they're actually understanding it. Because it may be completely clear to me in my head because I made up the question, right? And then Melissa's answering it and she answers something where I'm like, why did you answer that question? She's like, because that's what you asked. It's like, well, you need to make sure that's really clear. Relationship to other variables. So that might be examination associations between your survey data and external, or your assessment tool and other external variables. So that may be like convergence. If you're measuring 2 of the same things, they should be similar. Divergence, if you're measuring 2 different things, they should be independent of each other. Concurrent things, maybe things like a faculty in palliative care should be able to do this better than a medical student, right? So, so you may think about it in terms of level of training. That might be one of the concurrent measures. Predictive validity may be like, if you get this score on in training exam, that helps predict how well you're going to pass the boards, right? So that type of thing. And then consequences, especially for pass fail or something like that, you want to discuss the potential consequences of the impact of false positives or false negatives on the individual, on society, on patients and families. Okay. So the more innovative your idea is, your educational intervention is, the more you can get away with not having high level of these things, right? But you'll be publishing it slightly different. And Melissa will talk a little bit more about that. But like if it's a really amazing idea, think about it publishing it as a scholarly innovation in academic pediatrics. And you don't need high level outcomes. You don't need a huge population of fellows in order to do that, right? So the more innovative, the less will need this. The less innovative, if it's already been done somewhere before, the more rigor you need.
Thank you so much, Su-Ting. Yeah, I'll come off mute now. Perfect. And Katie, I totally agree. Validity evidence type research. So establishing validity evidence on a tool is really hard. It is not sexy, as you put in the chat. I agree. It was actually some of the most painful work I've done. It's not my favorite thing.
Same.
But yeah, but it is really important and really needed. So thank you for bringing that up. I agree.
It ironically is the paper I get emailed about the most, is a validity paper that I did not think was very exciting, but I get emailed about that paper more than anything else because people want to then sort of translate it or use it for their own studies. So it can be actually really, like, doing that over time showed me how important that type of work is, because people are really craving that assessment tool. So I think if there are people on here who are interested in that type of work, there's a pretty wide open lane for that type of research in our PEDS palliative care med ed work.
And I have a colleague here, Dr. Ben Kinnear, which I know we had a med peds person. He's med peds. He just finished getting his PhD in validity. And so he's an MD with a master's of education and a PhD, and he is a very popular person because it's really a cool skill set that not many of us have. So I agree. So we're going to come back. So at this point now, you have established your so what, you have this great gap in the literature, you picked your conceptual framework, everything has aligned with that framework. You recognize those methodologic flaws, you have the right outcomes, and now you're like, time to pick the journal. And I would say you probably want to pick the journal while you're creating all of the other things. Don't wait for this. Don't do this in a sequential order. But when you think about picking a journal, I often think about who. So who do I want to share this information with? Is this for other pediatricians? Is this for palliative care clinicians? Is this for researchers? Is this for educators? Is this for people in the public health space? Because they are all different journals. Also, what? So you pick that journal or two or three, and what have they published? Do they publish things similar? I love Lorelei Lingard's of "This is a story, not a study." And our story picks up on some prior story. So if a journal has published things similar, like how does my work add to that story and bring it further forward so then someone can continue to add to the story? If that journal has published other things similar to yours, that's terrific. Make sure you cite it, because it really shows the journal editors that, like, you know what they publish and that you are adding to the story that their journal is telling. And then really think about what is the best section, because even within one particular journal, there's many different sections. I'm going to talk about this on this slide because this is really, really important. So not all work needs to be a full-length research article. Yes, that's the book. Thank you, Naomi. Yes. So not all work has to be a full research article. There's lots of different ways to share. So there are some narratives I really like, and many other people do, because sometimes they close this section, the 12 tip section in medical education. It's the how-to paper. So 12 tips to do something. There's also those visual papers that are more around the clinical piece. So I know, like, academic peds has the nuts and bolts. Academic medicine has the academic medicine last page, and it's just a one pager and it's much more visual and it's very practical stuff. There's also these, I call them very brief reports, and they're pretty practical. And when I say very brief, they're 500 or 600 words, depending on whether it's really good stuff or new ideas. You have to be careful with the journals though, because they only accept those 1 or 2 times a year, depending on the journal. So make sure your work will align. Like really good stuff is usually November and May. And once that submission's closed, you have to wait to 6 months to submit again. And then even within our Journal of Academic Peds, so we have several different types of publication options. So we have our innovation reports, which are only 1,000 words. They're 10 references and 1 figure. And that's for something we really there are measuring the level of innovation. So if this is the first time someone has done this particular thing or looked at something in this particular way, and maybe you haven't created a lot of validity evidence, or your methods are lower on the on Kirkpatrick's evaluation triangle, but it's really cool and innovative. That may be a really great place. And then we have brief reports and full-length research articles. And you'll see, like, as you kind of move up to the full length, you need more validity evidence. You need to get higher on that evaluation pyramid. Or higher on an assessment score. And so again, just different things to think about. And then I also just want to plug MedEd Portal. So MedEd Portal is really great for curricula. And so always think about sharing your curricula. Other things to think about as far as journal fit is the journal's mission and vision. So if we get a submission on ECMO something, and we're like academic peds for that, it's just not our mission and vision. It may be great work, but it really doesn't fit with us. Depending on where you are in your faculty position, impact factor may matter, journal prestige may matter. I always think about your the quality of your work the best. And I can tell you, like, this work is really good and I'm going to shoot high. And this work was like cool and okay, but definitely shooting for different journals. And now there's the cost of open access to consider, because most of us don't have a lot of money. And so I like this. I use this all the time when I talk to fellows and trainees and junior faculty. So I have the 3 types of journals, and I always say, let's pick 4 to 5 journals that would be our selection. Let's do our reach. Whatever we think, like, this would be amazing and cool, and I'm sure we're getting rejected. Hopefully we get some good comments. 2 or 3 in the reasonable, and then I have my JLR, my Journal of Last Resort. And I try to pick those ahead of time and have written down, like, how many words, how many figures, so that when I get that rejection from the reach, I can quickly flip it to something else. I don't have to have a team meeting and wait a month and lose a lot of time. So how to identify journals? So the AAMC has a annotated bibliography that comes out every few years. The last one was released in 2024. And then I like this Jane site as well. And so here you can insert your entire abstract, you can insert your title, you can insert just some keywords, and then you can click that Find Journals, and it'll pop up all the journals that may publish things related to what you've done. And then here I click the American Journal of Hospice and Palliative Care. And then when you hit Show Articles, it shows you the articles in their journal that are related. So you can say, yeah, this really is related, or no, it's really not. And I shouldn't come to this. I shouldn't use this one. And you can see, like, on this list, it's pretty long, but, I put in medical education, palliative care, pediatrics, and evaluation. And, I got some really kind of different journals that I wouldn't think might be the right fit. So I use this as a starter and then look at each of the potential journals. So we're going to end with some top tips. I think, Su-Ting, you're going to take it off.
Yeah, so we'll do a few practical tips. So you want to try to align your scholarship with your passions and what your institution is going to value, so that hopefully it'll value with your time too. So that alignment is really important in terms of meaningful and aligned work. And then think about a career planning a series of studies. So it's not necessarily one study is the end of your career or whatever. You might have to build on it. And that's super cool to say, hey, this is the track of what the stuff that I'm going to build on. So that thematic work is really important. I'm in my institution, one of the things they look at is like, do you have some sort of thematic work in terms of that's what you're building on there? And then make sure you carve out protected time for scholarship. So what I do is I block out time on my calendar and I block it out and I call it research, and nobody else can put stuff in there. Fortunately, sometimes I put stuff in there, but at least you do that. One of my friends said what she used to do is like put like a sign in front of her when she gets with the office all the time in terms of like in a meeting, like on a call, but your call could be like you're actually doing research. So like thinking about what you want to do for that, but that's really important too. And then identify where you need help early. I 100% recommend talking to your statistician as soon as you're thinking about your project. I run with my statistician, so it makes it super easy to do that. We just finished the California International Marathon the week before. So I'm now walking normally. Awesome. And then seek out mentorship in terms of scientific career mentorship. Melissa and I have mentored lots and lots of people over the time, and it's super fun, right? That's like one of the best parts of your job.
And so I'll take the last 5 practical tips. So plan your analysis, plan your evaluation, plan your deliverables, like whether you're going to publish or abstracts or whatever, as you're planning your study. There's nothing worse than coming to the end and being like, uh-oh, now what? Break projects into smaller steps. So it's a lot to say, I'm going to write this paper, but say I'm going to copy the methods from the IRB and try to edit what we did differently. I'm going to, I'm going to build the tables today. Edit and proofread carefully. I have a colleague who is like my final editor. When I think everything is great, he reads it for the first time and finds all the double thes and stray commas and craziness that I have just missed because I've read it too many times. And then I apologize. I pulled up the checklist too early, but we will share the checklist that we use as well. Know that everything takes longer, so plan early and plan extra time and try to enjoy it. It can be challenging, but when it's done, and when you watch others go through it, it really can be fun. And so we are happy to take questions, and then I will also pull up the checklist. And then Su-Ting, my OneDrive never lets people share. Can you just share it in the chat? Thank you.
This was wonderful. I think people certainly have a lot of new and interesting resources to use and online tools and kind of the updated Kirkpatrick's. I realize we're kind of right at time, but I want to make sure that if people are here and have a question that they can pop themselves off mute and ask since we have some wonderful experts here with us.
We'll send you that checklist separately. I'm having trouble getting that too.
Yeah, you can send it to me, Su-Ting, and we'll send out like a little recap of the whole session. We can add it to that. I have the links to the other things to send out as well.
Great.
I guess we're a silent group today.
Yeah, I was thinking about when you were going up your Kirkpatrick's pyramid, how we do as a field we do a lot of research into communication science and how to help people communicate better and how to essentially impart palliative care skills into people, both within our specialty and outside our specialty. And that third rung of the Kirkpatrick's, how do you measure behavioral change and sustained behavioral change? And like, not only did they learn, as you mentioned, not only did they learn something that day because we're teaching really smart and, effective people, but how do you measure that behavioral change, whether it comes into the hospital? And I think that's a big challenge for us in our field. And I wonder if you have any thoughts on that specifically as it relates to palliative care and communication kind of education.
Yeah, so it may be things around, like let's say you threw a workshop together for your fellows or for your medical students around the approach to discussing a care plan or discussing goals of care. And you want to make sure that they actually do the stuff that they're supposed to be doing around that. So you may say, okay, I did like a simulation before and after behavioral stuff. And then you're like, well, when they go and talk to that next patient, are they actually going to use that? And that's what you need to go see. And so you may say, oh, I'm going to do that based on observation, like as a faculty member, I'm just going to come in and watch. Or I'm going to ask patients and families in terms of those questions, if there's something around there that you want to explicitly ask them. Or you're going to you can ask patients and families, how did that make them feel? Oh, I'm hearing the Melissa, I'm hearing something from your end. So those may be things that you think about in terms of those outcomes, in terms of, are they using what I taught them in this situation in that other situation, in real life? Are they actually doing that?
Yeah, it's a
So
really interesting
we've done
point.
a bunch of communication. It's in primary care, not in palliative
Yeah.
care. And so using your medical record as a proxy as well. So one, did they change their charting potentially? And two,
Mhm.
did they do something different? So we've done a lot of communication around vaccine hesitancy, and we really looked at what the outcome. So if you've learned how to counsel vaccine hesitant families, what should be the outcome? That more kids get shots in arms, right? That would be that return on mission, that we are vaccinating a higher percentage of children. And so we actually will study vaccine acceptance over time, pre-communication, post-communication, and have seen that. We've done some things on communication related to obesity counseling. And so one, looked at notes and what was addressed in the assessment and plan, but two, looked at when how often were obesity studies appropriately ordered. And so again, looking at yes, they learned and they said it was nice and they liked us and whatever. But then we looked at their 3 months before education, 3 months after education of the children who fit the criteria around which we were teaching. And that really gets you way up in Kirkpatrick. I do want to say, like, think about, and we took out the finer criteria.
Yep.
So as you're going up the evaluation pyramid, it takes more time, more resources, whether that's person resource or financial resource to pull things from Epic, et cetera. So just make sure whatever you decide on, that it's feasible and it's measurable. And so think it through, all of that stuff.
You could think about, like, I mean, maybe for adults, but like like how many pulsed POLSTs got signed. If
Yeah.
that's, if that could be like you're teaching around that, and you can think about how many times did they have those discussions and have actually those things signed, and those discussions around those, or how many documented blank happened around that. So those may be things that could be super helpful for you to see, hey, did what I teach actually get translated to them doing something different?
Yeah, I think there are definitely things that in our field would be applicable to that, around like code status discussions or pulsed forms or goals of care documentation, and then pairing that with other newer technologies like natural language processing and things that can comb through the medical chart in an easier way than your in your fourth year medical student. And really utilizing those two types of technologies together to assess like those lower levels of Kirkpatrick's and those higher levels, which would be interesting.
And NLP has a lot of potential. At least where I am, it's pretty expensive to find someone who has the expertise to build it for what
Yeah.
you're looking for. And so, just thinking that those fourth year or third year medical students are fairly cheap. And they do a nice job, and they have a research rotation and they love it, and they get to do a poster and then be on the publication. So, that's where that finer piece is. Like, don't try to create an NLP by yourself if you don't have that, if you don't have the funding to get someone to do it. Hopefully someday it'll be like, it'll be easy through Epic, but it's still pretty challenging.
Yeah, it definitely is. And our group historically has talked about how a lot of us do this out of love,
Yes.
and not necessarily out of funding or FTE or time, but that we're generally a group who is doing this because we care a lot, but not necessarily because we have like dedicated and protected time for a lot of this effort. So I hear what you're saying.
Yeah. And people that are not palliative care physicians have so much to learn from all of you guys and your approach to communication with patients and families. And so how you teach and talk to our medical students and our residents and obviously your fellows, super important. And the more that you can teach that in your approach to that, I think will be helpful, even if they're never going to write a post on a patient or whatever, like even just having their approach to making sure that patients and families are feeling heard and their goals are being discussed is really important. So thank you for the important work you guys do. I'm glad somebody does it, and I'm glad it's not me, but I'm really, really glad you guys are here.
No, thank you so much for joining us today, for helping us to edit our own papers and make our papers better as we have submitted them to your journals, and for teaching us about a bunch of cool resources that hopefully people can walk away with and at least take away something new from today. So that's what our goal is, obviously, in this series, and we really appreciate you being here. So thanks everybody for joining today.
Great, thanks for inviting us.